Good morning, everybody. Shall we start? Dear colleagues, dear friends, welcome to this first webinar for the introduction of the WHO Labor Care Guide. This tool for implementing the recommendation of intrapartum care for a positive childbirth experience, which was launched in 2018 by WHO. I'm Dr. Triphonie Nkurunziza. I will be chairing the meeting. I want to say welcome to all of you. This webinar is prepared for you in collaboration with UNFPA, UNICEF, WHO, and the World Continuing Education Alliance, supported by the Together for SRH program. I'm pleased and honored to present to you the agenda of today for the 2 hours that we'll have together. I don't know how to go to the next slide. So do you see my screen?
Yes, we see it.
Okay. So as I was saying, I'm Dr. Triphonie Nkurunziza. I'm chairing this session. And I hope you see on the screen the agenda of the meeting. The welcome, the overview of the agenda is what we are doing now. And this will be followed by the opening remarks. We will have the opportunity to have Fran McConville, Technical Officer for Midwifery at WHO headquarters, and Yoti Tewari, the Health System Advisor from UNFPA East and Southern African region. And we were supposed to have Dr. Geoffrey Bisoborwa, Director at I for the Universal Health Life Course at WHO Afro, but he will not be available because he had just been called to another equally important and urgent meeting. But I will do the opening remark for him. Then will be followed by the overview of the WHO Labor Care Guide that will be given by Dr. Mercedes Bonet, the medical officer at the WHO headquarters level. And then this will be followed by questions and clarification that will be led by Fatima Gohar from UNICEF SRO. And then 60 minutes really to go in depth on how to use the WHO Labor Care Guide. And this will be presented by, we do have experience from 2 countries, Argentina and Tanzania. Then we'll have 30 minutes of questions and clarifications that will be led by Muna Abdallah, the Health System Advisor from UNFPA SRO. And we have some remarks from Jennifer Nyoni, the team lead for the health workforce at the WHO Regional Office for Africa in Brazzaville. And then also by Fatima Gohar from UNICEF SRO. And then we'll have the next steps and the closure by Nancy Kidula, there is a slight change in the agenda. So if there is no comment on the agenda, I would be pleased to call upon Fran McConville, technical officer at WHO headquarters, to give her remarks. Over to you, Fran, and welcome again. This is very exciting.
Thank you, Triphonie. I hope you can hear me, and I think people can see me.
Yes.
You're good. Okay, so firstly, thank you to everyone who's joined, and hello from all of us. And it's just wonderful, really wonderful to know that there are so many midwives and others joining this really important meeting on the new labour care guide in Afro. And it's just so great to have so many midwives together, actually. So I'm Fran, and I am the Midwifery Technical Officer based in WHO headquarters in the Department of Maternal, Newborn, Child, Adolescent Health and Ageing. And I've been there for about 8 years and spent the previous 30 odd years working internationally in midwifery. And I want to thank all the midwives on the call, midwives and nurses, I am both, for your from WHO, really, for your hard work and commitment. You are working in the most extraordinarily difficult circumstances, and yet you continue to be dedicated. I think the DG and our Chief Nursing Officer, who's also a midwife, Elizabeth, are never, ever stop thinking about the hard work that you do. And in the Year of the Nurse and Midwife, you were really outstanding. We were so proud of everything that midwives everywhere did. But in Africa, my goodness, you really were outstanding. And we really appreciate you for that. We want you to know that. And especially around COVID, you have sacrificed so much to help others. So we really want you to know that WHO is so supportive of you and appreciative of you. And it's just wonderful that in huge numbers you have come now to learn how to take forward and how to improve quality of care during childbirth through this meeting. So just a couple of points for me as a midwife. I know that when you're a midwife who leads care, you fill out what was the partograph more than any other professional. You are the one who has that responsibility for the woman, her newborn, and the family all together. It really is life-saving. It's how you find out when things aren't quite right and you call in the right help, or you start referring, but it really makes you think. And it's also about accountability. The record is something that woman, the family, the baby will always have, but it also demonstrates when you use this partograph, now the labour care guide, well, that you're a real professional, you know what you're doing, and that's good for you because it shows that you have acted in absolutely the right way to give the best quality of care to that mother and baby. So the labour care guide looks different. We're all a bit used to the partograph, but I have to say it doesn't take too long to get into it. And when you start using it, it really is great. We know that we've been field testing it through our midwifery education program in the Southeast Asian region. And what I love about it really is that it's not just the clinical part of midwifery care. It really is about ensuring a woman has a positive experience of care. And that's where you as midwives come in. It's about her respect and her dignity. It's about her emotional support. It's about good communications. And for me, it's really exciting to see we can actually, it's really important on this form that we fill out something that says she's moving. She's not stuck on a bed, strapped to the bed with an infusion in. She's mobile. She's drinking. She's talking. She has a companion with her. She is been cared for during her childbirth. And that, as we know, releases oxytocin. It improves childbirth, makes it such a much more positive experience. So I don't want to say much more other than welcome. I think this is a really exciting day. Please enjoy this. You'll get the knack of it, I know. And hopefully when the pandemic calms down and we're all vaccinated, I'll get the chance to come and work with you and support you on this. So thank you again for joining. It's great to have all our partners on board. I'm going to say hello from Hilma at ICM too, because she's unable to join. So I'll hand back now to Triphonie. Thank you, Triphonie.
Thank you, Fran. I know how you are excited and passionate about this. Thank you very much for the words. And now I'm very pleased to call upon Yoti. Is it Yoti or Muna who will deliver the remark for UNFPA? You
Yeah, JT is here. Yeah.
Okay, Yoti, welcome, and you have the floor, please.
Thank you so much, Dr. Triphonie, and it's brilliant to see Fran. Fran, if I remember, I used to work for you in defeat, if you remember, long time back, I guess. Yeah. So I'm absolutely delighted to be part of this exercise, and on behalf of the joint UN team, WHO, UNICEF, UNFPA, and the World Continuing Education Alliance, I thank you all, and for taking time out for this webinar. And it's really, really amazing. I mean, we have over 400 people from almost all our Eastern Southern Africa country. That clearly shows this power of these digital solutions. So I believe in a short period of time, you are likely to translate this particular guidance into some kind of a modular e-learning and learning training. So that will be absolutely brilliant. And basically I have nothing more to say. We're absolutely delighted, and it all seems like falling into place. And this is our 16th webinar, if I'm not wrong. So, but I have three things for all of us to consider, particularly our leads from 3 UN agency at country offices. The first thing, in our region, we have over 125,000 midwife, nurse and auxiliary midwives. And the power of these digital platforms are so good. How can we expand this platform and bring in as many midwives into this platform? That's something for us to consider. And also, we all recognize many of our midwives perhaps do not have connectivity, perhaps do not have smart devices. What kinds of innovation we could think about. And we're really, really fortunate that we have resources for the first time to continue this platform for a while if we find it useful and successful. And then there are quite a few innovations that could be done, such as providing smartphones to maybe midwife through some kind of their salary adjustment, or bringing in the private sector. And already we are in conversation of few of those opportunities. So basically at the country level, I really, really request each one of us to look at innovative ways of reaching to as many midwives, nurse and auxiliary midwives as possible, and bring into this virtual learning platform. So that's the second one. The third one, some kind of a beyond this occasional webinar, because there is so much of interest. I'm just wondering whether we could also create a network, an ongoing network of midwives through this particular platform. So even if someone not able to join a particular webinar, a particular module, could still be part of our larger network, and then a two-way communication can take place between us and the midwives in the region. So with those three questions, basically, I again welcome you all and then hand it back to Dr. Triphonie. But as a UNFPA regional office and then the coordinator for integrated SRHR team in the regional office, we are so thrilled, and my RD and then my technical head and the headquarters is absolutely thrilled to be part of this platform, and then able to reach out to thousands of midwife, hopefully in a few months' time with SRHR solutions. So back to you, Triphonie, and thank you so much for this partnership. And then thank you all for participating in this important webinar. Back to you.
Thank you very much, Jyoti, for those encouraging words and those questions that are worth really taking on board. I'm pleased now to deliver the opening remarks from the director of Universal Health Coverage and Life Course in Afro, Dr. Bisoborwa Geoffrey. So those are his words. Distinguished participants, dear friends, dear colleague, representative from ICM, Nursing Registrar, National Nurse and Midwifery Associations, ladies and gentlemen, all protocol observed, good morning, good afternoon, from wherever you are. It's my distinct pleasure to be with you all today. This webinar jointly convened by WHO, UNICEF, and UNFPA SRO to introduce the WHO Labor Care Guide, otherwise known as the WHO Next Generation Partograph to midwives and nurses in the African region. Colleague, as you know, the death of women during pregnancy and childbirth and in the postnatal period continue to be a major problem in the region, with sub-Saharan Africa accounting for 2/3 of globally recorded maternal death. Current projection suggests that at the current annual reduction rate of 2.9%, Africa will not meet the SDG target for maternal mortality reduction of 70 per 100 live births by 2030. This calls for urgent focused and accelerated action by country if the region really hopes to end preventable maternal and perinatal mortality. We know from available evidence that improving the quality of care around the time of birth, including during labor and delivery, is the most effective strategy for reducing maternal and perinatal mortality with triple returns on investment. A key aspect of intrapartum care is monitoring labor, previously done using the partograph. In 2018, WHO launched intrapartum care recommendations for a positive childbirth experience with updated labor monitoring guidance based on available evidence. Subsequently, a new labor monitoring tool was developed to align with the updated recommendation for intrapartum care. This new tool, now known as the WHO Labor Care Guide, together with its user manual, was launched on 15 December 2020. You also know that WHO declared 2020 as the International Year of the Nurse and Midwife in recognition of your vital role, not just in maternal newborn health services, but in all primary healthcare services. In fact, the WHO Director General, Dr. Tedros Adhanom Ghebreyesus, has reaffirmed that nurses and midwives are actually the backbone of every health system, and especially for maternity care services. Their acceptance and understanding of the labor care guide is therefore very important for rapid uptake and utilization of this very important tool in labor and delivery units across the region. So we urge you, therefore, to pay careful attention to the explanation provided and to study the document given to you from this webinar. We also encourage you to disseminate the information learned through all possible forums that your peers and other health workers who did not have the opportunity to attend this webinar so that they can have a clear understanding of the new labor care guides. For those of you who are lecturers, professors, master trainers, we urge you to review your curricula and content to ensure that this tool is part of the pre and in-service training. In conclusion, allow me to thank for all of you to take the time to attend this workshop. I would also like to thank the panelists led by Dr. Mercedes Bonet Semenas from WHO headquarters, the World Continuing Education Alliance platform for hosting this webinar, the organizing team comprising of Fatima Goha from UNICEF SRO, Muna Abdullah from UNFPA SRO, and Nancy Kidula from the WHO Inter-Country Support in East and Southern Africa region. And for all the facilitating team for your hard work in preparing for and conducting this webinar. Let me also reiterate our gratitude to the Swedish government through the Together for SRHR initiative for providing the funding to support the learning collaborative. Finally, on behalf of the WHO Afro region, I wish to reiterate our commitment to supporting midwifery care in the region, and I wish you all fruitful deliberation. This is for our director. So now, please ready to introduce the Dr. Mercedes Bonet Semenas, who is going to actually give you all what is important to know on the WHO labor care guides. So Mercedes Bonet is a perinatal health epidemiologist. She's based in the Department of Sexual and Reproductive Health and Research at the WHO office in Geneva, and she has extensive experience in global health, with a particular interest on improving the health and well-being of women and newborns through research and development of evidence-based recommendations and tools around care during childbirth and the postnatal period, maternal infection, and sepsis. Dr. Mercedes will give us a 15-minute presentation on the WHO labor care guides, and I wish to welcome her to start her presentation, and I thank you.
Thanks, Triphonie, and I'm very pleased to be with you all here today. I will start sharing my screen. Okay, great. So we are here today to introduce you to the labor care guide, which we think is and will be a key tool for you midwives and nurses in the African continent. And as we have been calling it, this is our new next generation partograph, and a tool that will help us implement the recommendations on intrapartum care for a positive childbirth experience. We have structured our presentation in 3 main parts that we will be covering after presenting to you the objective of this webinar. I will start describing to you the labor care guide, and my colleagues Veronica and Rose will take you over in more detail on how to complete the LCG. And towards the end, we will also point you to additional readings and resources that WHO has issued along the LCG, including its user manual that you will be using throughout this webinar, but also the different manuscripts that we have published or are in press and that describe the process that we took to develop the labor care guide, as well as other WHO materials. We have organized the webinar in a manner that will allow, I hope, a lot of interaction and allow time for questions. So I hope that you will be posting those on the chat that we have for a Q&A, and we will try to responding to some of them written and then select some of them so we can respond to them live. And hopefully by the end of the webinar today, you will be as enthusiastic as we are about the labor care guide and its potential to help you in providing high quality intrapartum care. So at the end of the webinar, we expect that you will be able to identify for whom, when, and where the labor care guide can be used, recognize the principal elements and the sections of the labor care guide, and have a good understanding on how to fill out the labor care guide and what additional resources are available to help you to do that. So moving to the first part of the webinar, we wanted to start presenting to you the rationale behind developing the LCG, what is its scope and how it is structured. And that will be mainly my presentation before moving to the next part of the webinar on how to actually complete the tool. So why the labor care guide, and why we are moving from the previous partograph to this new revised next generation partograph, as we call it. This is mainly because following the publication of the WHO recommendations on intrapartum care for a positive childbirth experience, and that was in 2018, WHO initiated a process to revise the previous partograph to facilitate effective implementation of these recommendations. The recommendations are based, a lot of them, on a new understanding of the individual variability of labor progression that results in good perinatal outcomes, both for the woman and for her baby. And it also includes a set of recommendations that were informed by that global shift towards also improving experience of childbirth. And all this necessitated the design of a new tool that we call the WHO Labor Care Guide, and that you can see featured here on the slide on the right side. And in this sense, the tool is establish essential good quality and evidence-based care, but as I mentioned it in the previous slide, expands the focus also to allow a positive childbirth experience. And you will see how we are addressing these issues in the labor and care guide. So it is distinct from the previous partograph in its design, in the way it approaches labor duration and how this is recorded. It has now triggers to help providers identify deviations from normality, and also emphasizes respectful maternity care. But you will also see, and I would like to reassure you that there's a lot of the underpinning concepts of the previous partograph that are maintained in the labor care guide. And there are some of the sections, and you will see the variables that are collected and monitored that have not changed. What are the aims of the labor care guide? So the tool was designed for healthcare providers to monitor well-being of women and babies during labor throughout regular assessments, to also promote provision of supportive care throughout first and second stage of labor, assist you to promptly identify and address any emerging labor complication. And this is done by providing thresholds for labor observations and allow you to identify those that may deviate from normal, what could be considered normal observations. So that will trigger additional action. It should also allow to prevent unnecessary use of interventions. And this point is mainly referring to the new knowledge that has been incorporated in the LCG around labor progression, and with the ultimate effect, we hope that it will reduce unnecessary augmentation, for example, or cesarean sections. The tool also aims to stimulate shared decision making, and you will see the last part of the tool that is new allows for recording all the assessments and the plans of care that will be provided across and as the woman moves from first stage up to the end of second stage. And it's also intended to be a resource for audit, feedback, and quality improvement that could be used in your facilities to improve labor care. This slide is not moving. Okay. So before moving into the details on of the tool and how to complete it, let's see for whom, when, and where you can use the LCG. So it was designed for care of women and their babies during labor and birth. It includes assessments and observations that are essential for the care of pregnant women, and this is regardless of their risk status. However, in developing this tool, the approach that we took is that it was primarily designed to be used for the care of those women who came into the facilities in active first stage of labor and who are apparently healthy. So they have no risk factors. And I wanted to highlight that because it doesn't mean that you cannot use it in women who had risk factors or certain conditions, but they might require some additional care and specialized monitoring, including increased frequency on that monitoring or additional parameters that should be monitored and that are not those that you should monitor in all women and therefore were not included in the LCG. When should you start using the LCG? So when is that you open up a new page for that woman? This is to be done when the woman enters active phase of first stage of labor, and this is from 5 centimeters of cervical dilatation based on the new definitions that are in the 2018 WHO recommendations for positive childbirth experience. And this is regardless of her parity and membrane status. As the previous partograph, the LCG doesn't include the latent phase. However, and I think that this is, you all know, but we think it's important to highlight that those women still in latent phase need to be monitored and receive labor care and support during that phase of labor. Once you have opened a labor care guide, it will help you to continuously monitor women throughout first and second stage of labor. Where should the labor care guide be used? So it was designed for use at all levels in healthcare facilities. Also, what might be different at different levels of care is the plan of action and based on the protocols that you have in your facilities and the resources that are available, then the plan of action might be different at different levels of care for those women. Within the labor care guide should facilitate early identification of potential complications and therefore contribute to timely referrals too. So in the next 2 slides, I will introduce you to the labor care guide structure, and you will spend more time with my colleagues in each of these sections, and they will show you how those shall be used and completed. So you can see on the slide, and the labor care guide has 7 sections that are listed here, and you can see the different purpose.
Hello, Mercedes.
Yes?
Sorry, Mercedes, we can't see, your slides are not moving.
Sorry. So which one are you seeing now?
The labor care guide aims.
Sorry, what about that now?
No.
No, let me stop sharing and I will reshare. Let's see if, I'm sorry for that. What about now? Can you see them moving?
Yes.
Yes. Okay, so you stop seeing this one, right?
Yeah.
Okay, so I think that I don't have to repeat what I said, but just to show you. So for whom you can use the LCG, when you should start using it in the active first stage of labor, to be used at all levels in the care facility. And I was here. So you can see now a structure of the WHO labor care guide on the slide. Just confirming, Nancy.
Yep, we can see it.
Okay,
Yes.
perfect. Okay. So let me restart here. So the structure of the labor care guide, and this is what I will show you in the next 2 slides, and hopefully you will be able to see the next one. So it has different sections and components. 7 sections that are shown here, and the purple squares show the limits for section 1 up to section 7. And each of the sections have a list of observations that has to be monitored throughout active first stage of labor and second stage of labor. The first section is the one to identify the woman and labor characteristics at admission, and will allow you to record any important characteristic of the woman, her pregnancy, and the onset of labor that are important for labor management, but also to identify whether she has any risk. The section 2 is a new section called supportive care, and the aim of this section is to encourage consistent practice and respectful maternity care during labor and childbirth, and includes offering companionship, pain relief, oral fluids, and mobility. Sections 3 and 4 refer to the care and monitoring of the baby and the woman, and are there to allow you to regularly record important clinical parameters and their well-being. They remain basically the same as those that you found in the previous partograph, including fetal heart rate, position, and for the woman, the monitoring of vital signs. Section 5 is labor progress, and is where some of the changes were also introduced in comparison to the partograph. And although the principles of monitoring cervical dilatation and descent of the fetal presenting part against time remain the same as in the partograph, what have changed is the appearance and the limits that are now based on the most recent evidence that we have about labor progression. And this section also allows, and this is similar to the previous partograph, describing duration and frequency of uterine contractions. The last, section 6 is basically the same as in the previous partograph, and allows for a recording of use of oxytocin, IV fluids, or any other medicines that the woman should require during labor. And the last section is also new, and is called shared decision making, and is where we are prompting midwives, healthcare providers, to prospectively record a summary of the assessments that are done at a certain point in time, but also to prospectively record what is the plan of care and what are the actions that will be taken, either to continue monitoring that woman and the baby because progression of labor and all the other parameters are normal, or whether there's a need to manage any potential complication. So here you can see the LCG completed, and my colleagues, as I said before, will take you through. But what I wanted to highlight in this slide is that there's a time axis that goes throughout active first stage of labor and second stage of labor, and allows you to record the times of those observations. It has a column that is the Laisser column, and this column provides thresholds or parameters against which you can compare your observations. So to see whether there's any deviation and whether action is needed. And Veronica will explain you in a few minutes, but once there's an observation that hits the values in the Laisser line, you can circle them so they are highlighted, and you can visually see the problems that you have identified for this woman and her baby. We have published along the SCG a user's manual that was developed for midwife and other health personnel providing care during labor and childbirth. And it is meant to help you understand the tool, how to complete it. It gives some examples on how to do it. And if I can ask you just to have them handy, both the LCG and the user manual, as in the next part of the presentation, we will be asking you to refer to this document. So the link to download those documents have been already shared, but maybe we can share it again so those who join after that could also have access to those documents. So we have planned to stop here and have some time for questions before we move on to the next presentation. And thanks for your attention so far.
Thank you very much, Mercedes. And I think we do have 10 minutes for questions and answers that will be led by Fatima. Fatima, you have the floor.
Thank you so much. Thank you so much, Mercedes, for that wonderful presentation. Few questions what we have. There are very few questions for now, and let me ask if you could see the Google form where we have put all the questions. One is, has the other partograph been removed? And then basically one of our colleagues wants to understand how is this LCG different from partograph we used to monitor in labor? And maybe I think this would be, okay, there are other questions which are linked with practicality. For example, how do we start plotting the graph? And then also some colleagues are asking if there will be a Portuguese version of this guide, because it's not available right now.
Okay, maybe I can take
go
those
ahead.
questions, and then all the questions are more practical around how to complete it. We can come back to them at the end if the answers were not provided through the presentation. So yes, this labor care guide was developed as a substitute of the previous partograph, and this is why we call it the next generation partograph. It is an improved version, and as Fran mentioned it at the beginning, and I think that as you start using it, you will realize that the changes that have been introduced are those that will help you provide a better care to women and babies during labor. I tried throughout my presentation to point you to where the major changes were introduced and where the observations are pretty similar to the current or the previous version of the partograph. So hopefully, as my colleague take you through those, you will be able to see. And if we have time at the end, we can summarize in a brief manner those similarities and the differences. But basically, and as I say, the principles of the partograph are maintained, and the importance of continuously monitor women in labor are the same. The major changes that I can highlight is that section on supportive care, that it's also meant to ensure that those practices that are not clinical, but that will not only help with the experience she's having during labor, but we know that some of them will reduce unnecessary interventions that we at WHO think are very important. And then the change around the labor progress and how this is done based on 3 of the recommendations that you can find in the WHO 2018 guideline around new knowledge that we have, and we have what we have learned in all these decades about labor progression. So we are, in terms of translations, the tool is already translated into Spanish and French, and we will be soon publishing the user manuals also into those languages. We have no plans at the moment for a translation into Portuguese, but and that's mainly because it's not a United Nations official language, but we can certainly work with our colleagues in Afro office and see how we can ensure that this is available, as we understand that it's important for introduction in countries and for a number of countries in the African region. I'm not sure I understand the question about new topics introduced without logging in. Maybe that person can just reframe the question, and then we can come back to that one at the end.
Yeah, thank you, Mercedes. I think most questions, what our colleagues are very eager to know the practicalities of it, like, you know, linked to where is action line, alert line, decision, and all those things. So
Okay.
I just wanted to inform colleagues that please just wait, because we have other colleagues who would be presenting on those practicalities, and you'll hear more about it. So maybe I would say let's embark on to the second presentation, so then we can get further clarities, and we'll get back to you, Mercedes, in the next Q&A if need be.
Perfect. Sounds great. So I will continue sharing my screen for Veronica.
Okay, thank you very much, Mercedes and Fatim, for leading the discussion. We do have now two panelists that are actually going to show how to use the new photograph. We start by Dr. Veronica Pingray, who is a midwife and epidemiologist at the Institute for Clinical Effectiveness and Health Policy in Buenos Aires in Argentina. Her research focuses primarily on maternal and perinatal health, with special emphasis on postpartum hemorrhage, stillbirth, intrapartum care, and the use of cesarean section. Veronica was part of the team coordinating the research study and the project evaluation to develop the SCG and its user manual. So Veronica will present first, but let me also introduce Rose Laisser, who is a senior lecturer in midwifery and women's health from the Archbishop Anthony Mayala School of Nursing, the Catholic University of Health and Allied Health Science in Mwanza, Tanzania. She coordinated the team that pilot tested the labor care guides in Tanzania. So we are really pleased to have Veronica and Rose showing us how to use the new photograph. Let me give the floor to Veronica and then to Rose. Veronica, you have the floor.
Thank you. Can you hear me well? Well, let me know. Okay, thank you. So good afternoon. It's a great pleasure to be here with you today. We will explore together the new labor care guide, this tool that was specially designed to help us provide quality care during labor and childbirth. As I was presenting, my name is Veronica Pingray, and I'm original from Argentina. So I have a strong non-native English speaker accent. Apologies about that. Anyway, I will hope to be as clear as possible, but feel free to ask for clarifications via chat if any topic is not clear enough for you. During the next hour, we are going to explore the following topics. First, how to complete the labor care guide section by section, what resources are available to help you complete the labor care guide. We will solve some clinical cases together, and we will share some questions that we hope we can answer together. So we will invite you to participate in a live poll. Our colleague Rose will walk you through some clinical examples. So thank you, Rose. As for the poll, voting is completely anonymous and voluntary. it was mainly designed to interact with you and to verify if there's any significant clarification required. So we suggest that to participate in this part of the session, as Mercedes mentioned before, you have the electronic version of the labor care guide with you, and also, if possible, the user manual, given that we will use it several times during this session. I guess for many of you, this is probably the first contact you have with the labor care guide. And I have to assume that it could be a great challenge to get to know this tool in depth in only one session. So, however, let me clarify that there are some other educational resources already available for you that will complement this webinar and that will facilitate a deeper understanding on how to use the labor care guide. Okay, so let's start. Merce, would you move to the following one?
I've moved already. I think that I have to stop sharing and resharing again. Not sure what is happening. Can you say it now, Vero?
Yes, yes,
Okay.
Perfect. Thank you. So we all know that labor monitoring requires regular assessment to ensure the well-being of women and their babies. And the labor care guide will guide us on which parameters to assess, how to document them, when to intervene in the course of labor, and to make a shared decision with women and families. The labor care guide creates a positive feedback and decision-making loop as you, the healthcare personnel, are encouraged to regularly follow these 4 steps. The step 1 is assess, and that's to assess a list of parameters. This step involves assessing the well-being of the woman and her baby and the progress of labor. The second step involves recording, which consists of documenting these labor observations that we are assessing at different points of time. We will start using the first column of the labor care guide to record the first assessment and use the other cells on the right to record subsequent assessments. We will walk you through an example, and this will become more clear as we move forward. Step number 3 is to take the reference threshold. And this is mainly to compare our labor observation that we have just registered with the reference value in the alert column. And the last step that we usually record it at the bottom of the labor care guide involves deciding whether and what interventions are required. And ideally, this is made in consultation with the woman and documented in the labor care guide. It is important for healthcare providers to prospectively monitor women and babies' well-being and labor progression and apply these 4 steps at each assessment throughout labor. The labor care guide is intended as a guide, but it's not intended as a substitute of good clinical judgment. This is an important point. So quite frequently, the labor care guide will need to be adapted to each individual woman's circumstances and her preferences. The next one. So if we need guidance on how to complete, and probably at the beginning, you know, when we start using this in our own setting, we will need some support to start using the LCG, the labor care guide. So if we need guidance on how to complete each of these 4 steps. The user manual will guide you how to complete each of these variables. So if you can consult the manual now, that would be fantastic. So we can review together page number 12. And you can see that in step 1, this step will guide us on how to do the assessment, and there's a description how to do the assessment. In step 2, there's a description on how to record that assessment, including whether we need to record either a numerical value or an abbreviation, depending on the type of variable we are recording. Then we have some description on how to proceed with step 3, where we describe what are the thresholds that you might want to consider for each variable. And there's a brief description with some information that supports those thresholds. And finally, we have step 4, that is our plan. And there's a description that can guide you on how to continue monitoring, either in the presence of a normal observation, but also in case of an abnormal value of each variable. So as I mentioned before, it's quite likely that when we first start using the labor care guide, these charts will be consulted quite frequently. After a while, you won't need it, but probably at the beginning, it would be good to keep this resource in mind. The following one. So let's go step by step in an example. Let's evaluate the fetal heart rate. How do I assess fetal heart rates? I know for you, with your background, this is something quite simple. You do it in a daily basis, but it's just to walk you through the example and to realize what type of information we have available in these charts within the user manual. So the chart will describe in step number 1 a systematic way to control the fetal heart rate. In this example, the chart that you can find it in page 12 suggests to listen to the fetal heart rate for a minimum of 1 minute, auscultate during a uterine contraction, and continue for at least 30 seconds after the contraction, and the description continue. These mainly correspond. This is mainly in the user manual, but this parameter this step that we are describing, that is step number 1, is what we found in the first column of the labor care guide. So here we have all the list of parameters that we will be assessing, evaluating, and the user manual is the one that will give you some support with these descriptions. The next one. Okay, so let's move to step number 2, the previous one. Step 2. There you go. Thank you. So how do I record fetal heart rate in the labor care guide? And here the chart describes how to record these clinical parameters for the first stage of labor and for the second stage of labor. Where do I record it in the SCG? I record the initial evaluation in the first blank cell, where the first that we can see in blue color here. It will be the first blank cell for you, and all the following assessments will be recorded in the empty cells. The space where we record the assessment has to match the timeline in the top. So we record the time in the timeline and then the assessment at each corresponding time. The following one. Okay, so let's move to step number 3, and this is check the threshold. Where do I find the threshold for this variable? In the chart, of the manual, in the manual, I'm sorry, and in the LCT. So you will have both. There's a little more explanation in the manual. So we will highlight which are the values in this alert column for abnormal observations that require further assessment or actions. If labor observations do not meet any of the criteria in the alert column, labor progression and care should be regarded as normal as possible, and no medical interventions should be required. But it also highlights those abnormal observations that might require an action from our side. So we have descriptions in the chart in the user manual, and there's also, you can see an explanation supporting these values, but we also have the alert column in the LCT. So this can act, in daily practice, it can help us to remind what are those thresholds that probably will require some special attention or further actions when we are working with women and families. Just a very small but important clarification related to reference thresholds, that these are meant to use mainly as early warning signals. They don't, you can conclude a diagnosis based on only one of those values, and that they don't replace your clinical judgment. So these are mainly reminders and early warnings that can help us, can guide us, but should not replace your clinical judgment. So now we can move to step number 4. In the chart, this step will help us to plan how to continue labor monitoring and the care for the mother and the baby for each variable, and if there are any necessary actions that we need to apply. Once again, this is general guidance, and this mainly apply when all the parameters remain normal. However, it is expected that the required frequency of assessment will depend mainly on the results of all the labor observations and the observations related to the women and the baby's status. So once you complete all those assessments, it is expected that you record the plan at the very bottom of this page. In the chart that we see in the user manual, we have 2 different scenarios, some guidance on what to do if we don't meet the thresholds, and what to do if we meet the thresholds. But once again, these are for suggestions just to help you, but it won't replace your clinical judgment. The following one. So now we will go in more detail, into more detail, and we will review section by section. So we have just learned that the labor care guide is divided into 7 sections. The first one is usually completed only once, and that's when the active first stage of labor is diagnosed, while the rest of the sections will be completed several times throughout labor and childbirth. And we have the name of each section in the labor care guide. As you can see, it's quite tiny here, but section 2 says supportive care, section 3, baby, that is care of the baby, and so on. The only section that don't have a title is section 1, that is the one that we use only during probably the admission of the woman to labor care guide. So let's go through what section by section. The next one. So let's start, of course, with section 1. This is identifying information and labor characteristics at admission. This section is directly related to the definitions of the active first stage recommended by WHO in 2018. We have two new definitions: the latent first stage, which is a period of time characterized by painful uterine contractions and variable changes of the cervix, including some degree of effacement, and slower progression of dilatation up to 5 centimeters for first and subsequent labors. So that's the definition we will use for latent first stage. And we have a new definition for active first stage, which is a period of time characterized by regular painful contractions and a substantial degree of cervical effacement and more rapid cervical dilatation from 5 centimeters until full dilatation for first and subsequent labors. These definitions are especially important when using the labor care guide, because it is suggested that the labor care guide start being used once the woman has begun the active first stage. Let's move to the second one. Yes, so let's see what section 1 consists of. Section 1 is for documenting women's name and labor admission characteristics that are important for labor management. Those are mainly parity, mode of labor onset, date of active labor diagnosis, date and time of rupture of membranes, and risk factors. Risk factors, we can have a long list, but we are trying to register mainly those that are relevant for labor monitoring. This section should be completed with the information obtained when active labor diagnosis is confirmed. Here at the bottom of the slide, we can see an image of section 1, although it's we cut this image to make it bigger. It still look quite tiny. So if you have the labor care guide at hand, it will surely be easier to read it in your version. So let's try to take a look to the file you have to review in more detail. The following one. So as mentioned before, it is likely at first that we will require some guidance to complete each section until we get more familiar with the tool. So if we can go to page 8 in the user manual, we will find a chart that it was specially designed to complete the variables in section 1. As this section is usually completed in a single step, just after the woman enters the active first stage, it does not have guidance for this 4th step that we will follow for most of the sections. In this case, we will also provide some guidance on step 1, that is the assessment, and step 2, that is recording. It doesn't really apply step 3 and 4 for this section in particular. But you can see that we can find here more details. You know, we list all the variables in the first column that are in section 1, and there's a brief description of how to make an assessment, or some guidance on how to make an assessment, and then there's guidance on how to record it. And how to record it, it will be somehow useful because we will also describe all the different categories for those variables that require abbreviations. We will use abbreviations quite a lot in this labor care guide because of the space that is available to it is not so big. So we will provide all that information that is necessary to use abbreviation in step number 2. But let's go through an example that will probably help us to understand a little bit more how to complete the labor care guide. Rose, are you ready to present the example?
Rose were having trouble with her connection, so maybe I can take you through the examples and hopefully Rose will join. Rose have used the LCG in the pilot testing study that we did, and hopefully she will join and be able to be here with us. So on how to complete this first section, this is the example that we also use in the user's manual to help people understand how to complete the LCG. So I will just read the example so you get to know the woman that we will be supporting during labor in this presentation, and then show you how to use this information to complete this first section. So this is Mary Jane, is a low-risk pregnant woman. She presents with contractions and says that she has experienced leakage of fluid from the vagina for the last hour, and this was at 6 a.m. Her gestational age is 38 weeks. This is her 4th pregnancy. She previously had 2 births, one live birth and one a stillbirth at term. And she also had a miscarriage. She's taking oral iron to treat her anemia. The midwife in charge of the admission asked all the necessary questions to take her history and offers Mary Jane a clinical evaluation to assess the baby's well-being and her labor stage. The midwife found that Mary Jane has regular contractions, 3 every 10 minutes, and she's 5 centimeters dilatation with ruptured membranes. So just coming back on this slide on what Veronica explained you about this loop of assessing, recording, and planning for her care. When it comes to this section 1, what you will be doing is assessing and taking her history, and then recording in this section at the top of the labor care guide your findings and the information that will help you manage her labor better or identify any risk. So this is how it looks like when you complete the section 1. So her name, parity, based on the information that we have here about her live birth and stillbirth, spontaneous labor onset, the date, rupture of membranes, the dates, and also the time. And as this is estimated to had happened at 5 a.m. And then as risk factors, her history of having a stillbirth and anemia, and she is taking oral iron for that. So now we wanted, and we will have, as Veronica explained, some questions throughout this presentation, just to make this presentation a bit more dynamic. So the first question, and I think that you can see the poll option already. The first question is, should a midwife use the LCG when a pregnant woman presents to the healthcare facility in active first stage of labor? And this is 5 centimeters cervical dilatation or more. And you have to option yes or no to answer. Remember, this is completely anonymous and it's just for the fun of having a bit more of interaction with you. And then I will pass over to Veronica when we have the responses. So she will give you the right answer and tell you why.
Let's give a few seconds, and I think there are many people voting. That's good. Okay. So this could be a few seconds more, and we will be ready to close and see the results.
You just stop it when you wish, Veronica.
Yes. Okay, the last few seconds to vote, and we will close it.
Hello, Veronica. We have many people voting in the chat. Please, can you vote on the online questionnaire that is showing on your screen, not in the chat?
Thanks, Nancy.
Yes, thank you. That will allow us to show you the results. So ideally, you should be voting in the poll that pop up in your screen. Okay, I think I will end up the voting now so we can see the results, which are really good. Okay, can you see the results?
Yes.
I think that people can see them.
Okay, great. So almost all of you chose the right question, that is yes. And don't feel bad if you have chosen option 2. It's the first contact with the LCG. So yes, that is the right question, the right answer. Documentation on the LCG should be initiated when the woman enters the active first phase of the first stage of labor. That is 5 centimeters or more of cervical dilatation. And that is regardless of her parity and the membrane status. So although the LCG should not be initiated in the latent first stage of labor, it is important to clarify that it's expected that that woman and the baby are monitored during the latent first stage. They should be monitored, but it shouldn't be recorded in the labor care guide. The labor care guide was designed to follow up all these parameters starting at 5 centimeters of cervical dilatation. So thank you for participating. We will have some other few questions when we move through the presentation. Okay, so let's go to section number 2, and this is supportive care. This is a new section, a very important one. And this section is directly related to the following recommendations for intrapartum care. So it's related to respectful maternity care. That is a fundamental human right for all women, and is a core component of the WHO intrapartum care recommendations. This section is also related to these other recommendations. Companion of choice is recommended for all women throughout labor and childbirth. Relaxation and manual techniques, parental opioids, and epidural analgesia are recommended for healthy pregnant women requesting pain relief during labor and childbirth, and this will depend on women's preferences. Also encouraging the adoption of mobility and a birth position of the individual women's choice, including an upright position is recommended. And for women at low risk, oral fluid and food intake during labor is recommended. So these are the guiding principles when this labor care guide was designed. Let's move to the second one so we can explain section 2 a little bit more. There you go. Thank you. So section 2 of the labor care guide, that is supportive care, aims to encourage the consistent practice of respectful maternity care through the continuous provision and monitoring of supportive care. This includes labor companionship, access to pharmacological and non-pharmacological pain relief, ensuring women are offered oral fluid and techniques to improve their comfort, such as encouraging women to be mobile during labor. Here at the bottom of the slide, you can see an image of section 2. We have the 4 variables and the alert values or the thresholds we need to use as reminders. If you have the LCG handy, please try to check this. It will be much easier to see it in your own version. So we will record in the first column that is empty right now, and we will continue recording further assessments in the other blank spaces on the right side of the LCG at different points of time. So let's check what the user manual suggests for completing this section. The next one. So if we go to page 10, we can find the chart with each of the variables of section 2. Now for this section and all the following ones, the charts will recommend how to complete the 4 steps to use the labor care guide. The variables will describe we will describe the variables and how to evaluate them. In the second step, it will be explained what options you have to record this variable. The third one will represent the alert values. And finally, we will have some guidelines on how to proceed in different scenarios for continued monitoring. So we can see you can review it in more detail, the examples that we have. And here we are showing that in the bottom of the LCG, we have a list of abbreviations that, after a while you won't need to look at them, but at the beginning it would be useful to use to identify where this section is. Here you have some brief instructions and a list of abbreviations, mainly for variables like these ones, the ones that are in supportive care that we won't be able to write, and we will need abbreviations. And ideally, to be consistent, we should use it in a consistent way so that anyone in the team can understand our assessments and what we are recording. So there's a more detailed list of abbreviations in the user manual in the pages 6 and 7, but you still have this short list here at the bottom that it will be useful. There's one practicality regarding this section. Supportive care measures should be offered and evaluated continuously during labor and childbirth. So we are recording these variables on every hour, but this is more, because we need to find a practical way to record these practices, but actually we will be offering and trying to assess continuously all these parameters during during labor and childbirth. We have an example and we can see how to complete this section.
Thanks, Veronica. So Rose just joined. Hi, Rose.
Hi, everybody. Sorry.
So do you want to just kick off with presenting the example?
I can.
Okay, sure.
Yeah.
So I'll let you go.
Okay, thank you. So we can see this example on how to fill section 2. This is an example of Mary Jane. She received a general and clinical assessment and she has been admitted to labor ward. She is monitored by a midwife on duty, but then she's not accompanied by any relative, someone from her social network. She reports feeling significant pain due to uterine contractions and requests pain relief. And she drank fruit and is walking. Now the midwife who is caring for monitoring offered her a companion of her choice. Mary Jane wanted to be accompanied by her sister, and the midwife gave directions to Mary Jane's sister as to when and how to call for assistance.
Rose, people are saying they can't hear you.
Oh, should
Just maybe come closer to your mic.
Yeah, thank you. So I'm saying Mary Jane is with her sister now. She's receiving instructions. Can you hear me?
You're very far. Your voice is very. Can you get closer to the mic, maybe?
I am. Maybe you read it for them. I am close.
Better. Okay, better.
Now it's better, I think. Mm-hmm.
Okay, then. So I was reading a Mary Jane's case, as you can see on your screen. On this last sentence, you are saying Mary Jane is with her sister now as a companion, using relaxation techniques for pain relief. She has been drinking water when thirsty, and Mary Jane is now lying in bed in a supine position. Can you move to next slide? Now, if we want to document this, we can see the records for Mary Jane. On step 1 of assessment, you fill in a place for her records, for her data, and if the woman is assessed well, I'm very sorry. If the woman is assessed well, the records are as you can find them here. The threshold is written. Maybe you can go through. Yes, thank you. You can go through your manual later to observe more on how you can fill this. But all the records which we have read in the section can be filled, as you can see, following the assess, record, and checking reference threshold. So in checking reference threshold, we are comparing labor observations with the reference value on alert column. Next. For those who can't hear me, you can see the example on your screen where we have highlighted not accompanied by a relative, issues on fruit fluid, juice, and walking, and also pain relief. These are key issues which you need to record on your labor care guide. Note the time, a replacement of a companion on the sister, and relaxation techniques for pain. You could see issues of dehydration, drinking water, and lying in bed. This is what we noticed in that example. So I'm seeing other people do not hear me, but I give you 2 minutes to read and check on your screen.
Rose, I will move to the next slide. Is that
Please
okay?
move. Yeah, it's fine.
Okay, so now, Veronica, I'm back, and we will review now section 3. This section, it's about the care of the baby, so we are all more familiar with this section that is quite similar to the previous paragraph. This section is directly related to these recommendations listed here for intrapartum care, intermittent auscultation of the fetal heart rate with either a Doppler ultrasound or a Pinar stethoscope is recommended for healthy pregnant women. Continuous cardiotocography is not recommended in healthy women undergoing spontaneous labor. It is recommended to auscultate every 15 or 30 minutes in active first stage of labor and every 5 minutes in the second stage of labor. And there's some guidance on assessing caput, molding, and the status of amniotic fluid regularly during labor to identify risks of adverse birth outcomes. The next one. So section 3, care of the baby, was designed to facilitate decision-making while we are monitoring the well-being of the baby. The well-being of the baby is monitored by regular observations of baseline fetal heart rate and decelerations in the fetal heart rate, as well as the amniotic fluid, the fetal position, molding of the fetal head, and the development of caput succedaneum. Here at the bottom, we have the image of section 3 and all these 6 parameters. And as we know, the second column will give us the reference thresholds as reminders. This next one. Let's check how to use the user manual for completing this section. If you go to page 12, we will find the chart with each of the variables of section 3. The charts indicate how to complete each of the 4 steps that we recommend for completing the labor care guide. So if we can go to amniotic fluid, we can assess what is the status of the membranes. In the step 1, is there leakage of amniotic fluid? If yes, what is the color of the amniotic fluid? Then we have several options to record this assessment. That is step 2. We can use I for intact membranes, C for when amniotic fluid is clear, N for meconium stained fluids, or B for bloody stained fluid. So we will find a lot of guidance there that should help us completing the LCT. Then step 3, there would be the alert values for this variable. So we can see that thick meconium and blood-stained meconium are the alert values. And finally, we have the section, the plan section, and some suggestion on how to proceed with the monitoring of labor after each assessment, either if we found that this observation was normal or abnormal. Okay, we can go through the example now.
Should I read for them?
Yeah? Yes.
So, this is example number for section 3 completion. We all know section 3 is about the baby. So the baby moves during monitoring and shows a heart rate of 140 beats per minute at 6 p.m. without deceleration. Vaginal examination shows 5 centimeter dilatation, cephalic presentation, and there is no caput or molding, and the fetal position is occipital. Amniotic fluid is clear. At 6:30, fetal heart rate is 136 at 6 p.m. without deceleration. At 7, fetal heart rate 132 beats per minute with variable deceleration. Now at 7:30, we see fetal without deceleration. The midwife checks Mary Jane's pad and observes that the amniotic fluid is still clear, given that the other clinical parameters are normal and that Mary Jane is coping well with labor. Her midwife continues checking fetal rate every 30 minutes as per rule, and will check the amniotic fluid during the next vaginal examination. Now, to complete this in labor care guide, let's check the next slide. Here we see again, we have highlighted important parameters, which is time, as you can see, the 140 beats per minute without deceleration, caput and molding, and fetal position occiput to posterior. Amniotic fluid is clear. You have seen that. And fetal rate here is highlighted. Again, all the times are highlighted. We see the fetal heart rate 148 beats per minute without deceleration at 7:30 p.m. So we see the labor care guide below here. We can see the baseline fetal heart rate, and then 136, 152, and for deceleration we find here normal, normal, varied, and normal. Fetal position here, occipital position is being highlighted. So when we get a woman with such, it's easy filling in the labor care guide. Next. Next. Now, let's check ourselves with some practical examples. This is the question for everybody to respond. Should the midwife cycle observation meeting a criterion in the alert column to highlight normal observations? So you can vote as guided. Either yes, put 1, or no, put number 2.
Okay, so we open the poll. You can start voting. Thank you for the participation. It's very nice to see so many people voting and so fast. So should the midwife cycle observations meeting a criterion in the alert column to highlight normal observations? Is it for normal observation or for abnormal observations? Okay, people still voting. We will close quite soon. So it's recommended to cycle the observations. And we have to decide if we do that when our observation is normal or abnormal. Okay, let's close and see the results. Wow. Okay, this is really important for us because it requires some clarification. So all the list of thresholds are reminders for us that we should take every time we complete the LCG. We compare our observation with that threshold. And if we meet that criteria, it means that we are reaching a threshold, and that requires some special attention and probably some actions. And we are planning to cycle those observations that meet the criteria from the alert column. So we will cycle abnormal observations. So this will be useful for us in order to make the right plan to continue monitoring labor and also for our colleagues if we are working in a team and we are highlighting that relevant information for them. So the right answer is option 2. Healthcare providers should cycle any observation meeting the criteria in the alert column. This is mainly to highlight abnormal observations, and this should help to highlight those observations that require special attention. Well, thank you for participating. Okay, let's go to section 4. This is another quite familiar section for us. This section is directly related to the following guidance for intrapartum care, that we know maternal temperature, blood pressure, and the urinary output should be regularly monitored to identify risk of adverse birth outcomes and to assess the well-being of the woman. The next one. So section 4, care of the woman in the LCC, it was designed to facilitate decision making.
Veronica, so sorry. I want to go back to section 3. Some colleagues are asking clarity on your on the explanation for the answer which you have given. Is it yes, no, and if it is whatever it is, what is your explanation? They're still asking the question. Yeah, please.
Okay, yes, sure. So we should not cycle observations, normal observations. So we shouldn't cycle when we have a normal observation. Sorry if this was so confusing, but it's a good chance, a good moment to clarify this. So for example, what we are seeing in the screen here, the only one that is cycled is P of posterior. And if you see the column next to this observation, actually P and T, posterior and transverse, are our thresholds. So when our observation match the value, the reference value in the alert column, that is what we are highlighting. Because we want to highlight what is a threshold and which requires special attention. We are not highlighting normal observations. We didn't highlight, for example, amniotic fluid that was clear or caputal molding that were normal. I hope that clarified the point.
And just to show here, for example, the example on supportive care, where that care is not available or not requested by the woman, for example, and it's no, then it's also circle here in the example.
Okay, so go back to section 4, care of the woman, which this is an easier section because we are more familiar with it. And this section was designed to monitor the well-being of the woman by the regular observation of these variables, pulse, blood pressure, temperature, and urine. And here we have the image that we can find in the user manual and how it's suggested to be completed. There's some guidance in page 15 of the user manual. And we can find how to complete each of these variables. The chart indicates how to complete the 4 steps. Step 1, once again, we have the description on how to perform the evaluation. The second step explains which are the options to record what we have just evaluated, our own observation, then the alert values in the step 3, and finally some guidance on how to proceed with the plan. All these observations are evaluated and recorded every 4 hours, and you will find in the manual some different guidance. Depending on the section, there are There could be different frequency for monitoring, but this depends on each clinical case. So these are only suggestions, but if everything is perfectly well, we can assess this every 4 hours, but this could be completely adapted to each clinical case and in accordance with local guidelines. It is expected that the required frequency of assessments will depend not only on the result of one observation, but all the observations that evaluate the status of women and babies' health. So yes, Rose?
Rose, just for in the interest of time, I was wondering, I will move to the next slide and so people can see how to complete the LCG with the information we provide. So we can at least cover section 5 today.
Fine. So we can see an example of how to complete care of the woman. As my colleague has said, this is an area where that's what we've been using the previous photograph, almost the same. But here we see the highlighted parameters of Mary Jane at 6 in the morning and then at 10. These, according to previous question, you see we highlight the abnormal. You see? So, for example, Mary Jane passed urine at admission without protein or acetone. So you look at if there's protein or acetone. And 10, Mary Jane passed 96 beats per minute with blood pressure 124/84. Temperature, you see, normal. She passed urine again without protein or acetone. So you see, key thing is protein, acetone. I think we can see how it is. The urine plus is negative, is dash. Temperature here, normals are here on their left, but then we see 36.5, 36.9. They are filled in as Mary Jane presented. Okay. Let's see again a small practical question. If we ask, does the frequency of recording maternal well-being in labor care record depend on woman's clinical status? The question number 1, you are going to vote either yes by putting number 1, or yes, and or you are going to vote 2. Thank you. Someone start.
Okay, we can start the poll. Now it's available. So does the frequency of recording maternal well-being in the labor care guide depend on woman's clinical status? So as a clarification, we usually provide some guidance on the frequency of monitoring, but we try to see here what's more relevant. What is this guidance that are in the chart, or women's clinical status, and what we found in each particular clinical case. Okay, these are the last seconds and we will close and show you the results. Okay, we are closing. You can see the results now. And this is good for us because we have the chance to clarify this. I know it's a lot. It's the first time we are reviewing the labor care guide. And the right answer is yes. So although the labor care guide and the user manual suggest certain frequency of monitoring, and this will happen not only in this section, for each section, including the labor care guide, it is really important that healthcare personnel adapt the monitoring frequencies. Sorry, I think you couldn't see that. To each particular clinical case, and also in accordance to local guidelines. So this is a very important point. This is just a guidance that might help, but it is more important to analyze the woman's clinical status in each clinical case and make decisions based on that, on how frequent I should be assessing and recording all these 4 parameters related to maternal health. Okay, thank you for participating. We are now moving to section 5. We are getting close. There you go. Thank you. So,
Veronica, I think this will be a good place to stop and take questions, because we have a lot of questions in the chat, and maybe we can continue next time. I think it will be good to stop at this point. We have very, very many questions.
Okay.
Yes, okay. I think Muna will take us through the discussion.
Okay, thank you very much, and good afternoon, colleagues. Can you hear me?
Yes, we can hear you.
Yes.
Okay, so there are a lot of questions, as Nancy said, and maybe we start with some of them and then continue. And some of the questions which comes very repeatedly is in the new labor care guidelines, should we consider active labor being 5 centimeter or 6 centimeter? And what makes the difference starting active phase from 5 centimeter, but not 4 centimeter like before? This question, a number of people have asked this question. And the other is, please, if you can answer whether the previous partograph is going to be phased out. And if so, when is it going to be, this LCG is going to be initiated or started in the country and in the health facility and so on? And a related question is, what is the legislative framework to initiate these new recommendations? Maybe let's start with those 2 questions. And I think it's related with Mercedes' presentation, or Veronica and Rose.
Yeah, I can start, and then Veronica and Rose can add to my responses. So I have been answering a lot of those questions around definition of active first stage, and it is 4, 5, or 6 centimeters. And I know that you were probably teach and use and were using the 4 centimeters definition, but WHO revised the evidence, and in the 2018 guideline, there's a number of recommendations on new definitions, and active phase is defined as of from 5 centimeters. And this is because what the evidence shows is that the inflection cervical time of cervical dilatation, when women pass from progressing slow to a more rapid progression in cervical dilatation. And I just wanted to refer you to that document if you want to look at the evidence underpinning those changes. The LCG is the tool that is replacing the previous partograph, and we gave some background at the beginning on why is that, and one of the reasons being these new definitions of active first stage of labor, the new knowledge that we have around labor progression, and also that willingness to also include the experience of care in into a labor monitoring tool to improve quality, as well as trying to address some of the issues about, for example, retrospective completion of the partograph when there was no plan across labor that had needed to be recorded. In terms of the legislations and kind of changes that will be needed, included in training, I think that at the beginning, in the opening remarks, some of my colleagues referred to that, and we will be working closely with the different agencies and with countries to introduce the labor care guide, and also with facilities. So the idea is that we will support the those that want to introduce a labor care guide, let's say now, and early adopters, but we will be developing additional tools so people can just take it forward and make sure that all women in all countries can be cared with the LCG. So this will require some time. Of course, we have thought about all these different issues and have started working with the stakeholders on that. But I just wanted to say that we also need you on the ground to help us introducing the labor care guide in your clinical practice, and from where you are also, you know, passing the information up. So the enable environment is there, and we really count on you for this. I think Vero or Rose, I don't know if you want to add something.
Well, you have said it all, but on section 5, when later we'll find the WHO recommendation for this, where the labor may not naturally accelerate until a cervical dilatation threshold of 5 is reached. So if people do go back and refer to all those recommendations, WHO recommendations 2018, they'll see the reasons why it has changed. That's all.
Thank you very much, Mr. Veronica. Do you want to add anything?
No, I think it was covered. You know, the LCG will be useful starting at 5 centimeters. And before that, we insist that women require monitoring, but the LCG itself, if you start using it, it won't be so useful. You won't have some thresholds. So that's why it's important to complete the LCG to start with the diagnosis of active first stage of labor.
Thank you very much. And I see a lot of people also appreciating the presentation and a really useful webinar. Congratulations to the presenters. Now moving into other questions for Veronica and Rose, maybe there are some detailed questions like, you have 2 cells for each hour on the fetal heartbeat monitor, FHR. Are cells meant to be filled in 30 minutes apart or both at the same time as a range?
Yes, thank you for the question. So we will use each cell to record the fetal heart rate, one for the first 30 minutes and the second one for the second 30 minutes. So we will record this observation every 30 minutes, and we are using a different cell. Some other observations don't require such a frequent monitoring, and that's why we can, you know, the space is a little wider. And if you use the chart in the manual, you can see that some others will even, you know, it would be suggested to leave it blank, not to complete it, because, for example, all those variables related to maternal health don't require recording and assessment on a hourly basis. we won't record it every hour, so we just keep it blank and record it every 4 hours. So that's why each variable, you know, there are, it's suggested to be recorded or monitored with different frequencies, and that's why the space provided could be a little different for each variable.
Okay, thank you. I think that that will clarify. Another question is, why are some time highlighted? Some of the time are highlighted and some not.
Oh, I think that was mainly something practical to show the example. So what is highlighted is mainly to show that it has to be recorded in the timeline. But actually, you know, what we record in the timeline is the time that we initiate, that we start using the labor care guide. And then we need to match the time, the real time, with the hours of labor. So it will always be more or less the same. If we start at 6, then we will record 1 hour in each of the subsequent cells, the following cells. If we start recording at 5, the second one will be 6, 7, 8, and so on. And once the woman complete the full dilatation, we will stop recording in the first section, that is the active first stage, and we will jump into recording time in the second stage. But we should be recording the real time hourly.
Okay, thank you. Another question is, they wanted to know if the new partograph has provision to newborn details and monitoring within the first 6 hours post-delivery, like the old partograph.
Can you repeat that question, sorry?
Yes, yeah. That the new partograph have provision to the newborn details and monitoring within the first 6 hours post-delivery?
No, this is not included in the LCG. Let me just, well, you probably have it.
Yeah, and another similar question is, any section considered to monitor immediate postpartum period with the new partograph?
I just wanted to come to a slide where you can see it if you don't have it handy, but okay. So the labor care guide includes the active first stage of labor and second stage. And I saw a lot of questions also, and I would add on latent phase, which is not part of what has to be recorded in the LCG. It doesn't mean so, and this has to be clear, that there's no need to monitor and to support those women in the latent phase. But we open, as we were opening before, for example, the modified WHO partograph at 4 centimeters, so the active first stage, we open the LCG at 5 centimeters, the new definition for active first stage. And what changes here is that we added second stage, that is not part of the previous partograph. And there's no recording of third stage or the early postnatal period. It doesn't mean that it's not important. And I know that in some countries, partograph was modified to allow some key variables of clinical status of the woman or the baby to be recorded in the partograph, but this was not part of the modified WHO partograph. We expect countries and facilities to adapt this tool, and those are some adaptations that could happen, but what you can see is that it's already very crowded for a one-page document. So anything that is added might need an additional page, for example, to allow people to record that information if they think that it's important. I understand that sometimes it's the only paper where labor and early postnatal care is recorded in some facilities. So I completely understand the concerns about not being able to have everything that we would like on one page.
Okay, thank you very much. And then another question is, the presentation so far focused on first stage of labor. How about the latent phase? And similar question also somewhere that sometimes complications happen in latent phase, and how do we monitor the latent phase?
Yeah, I think I mentioned that issue of the latent phase in my previous response. I don't know, Vero or Rose, if you want to add something. But I'm repeating what I say, but it doesn't mean that it doesn't have to be monitored or recorded in her medical records. But when it comes to continuous monitoring labor, the active first stage of labor is when we recommend people to open the LCG and use this tool for those periods.
Okay, thanks. And in terms of implementation, is there a geographic difference, or is this a global guidance, or is it only for Africa or low resource setting?
I saw that question on the chat, and it is a global guidance, and it was developed with that spirit in mind, but an international group of people, and we took it to different stages. And if we have time next on the next webinar, we could tell you more about how the tool was developed and tested. But the pilot testing that we did was performed in 3 countries in Africa, 1 country in Latin America, and 1 country in Asia. And as I mentioned it before, there's translations on the way and additional translation in other languages that we have already planned or have to consider. So this is meant to be a global tool, not only for Africa.
Okay, thank you. And Lesotho already have make a decision or to adopt the WHO labor care guideline in May 2021, and congratulations for that. Also probably the first country to adopt after the launch of the guideline. And they have requested a presentation. I think all the documents, including the records, will be shared. Another question is in terms of practicality, especially in terms of the timing of the monitoring. For example, on fetal heart rate monitoring every 5 minutes, especially using a fetoscope, the practicality is, there is a few questions around the practicality.
Yes, I can take that, Merce, if you want. So it is recommended, it was recommended by the experts that developed the WHO recommendations to assess fetal heart rate every 5 minutes during the second stage. And we know, you know, as you mentioned, there's it's a big challenge to record fetal heart rate every 5 minutes. So there, what we do is mainly to select the value that it has a higher relevance in terms of the clinical practice. So for example, this will happen the same with how frequently we assess uterine contractions. We don't have space to record it so frequently. So what we record, we select that value that it has the highest clinical relevance, and that's what we will be recording in that cell, in the space provided.
Okay, Thank you so much. And I think maybe the last question is around the positioning of the mother. Why are we restricted to turn the mother on the left instead of allowing them to turn on left or right, depending on which side improves the fetal heart rate?
So I guess that is more like a clinical question, and you know, we might want to invest the time in trying to review how to complete it, but actually in the guidelines we have cited 2 other documents that are very useful for clinical practice. So if you go to the manual, you will have 2 other guidelines from WHO that will be very useful, and there you will find this type of answer for clinical questions.
Okay. Okay, I think in general, these are the questions. Thank you very much for the clarification. If there is any important question I left, please, Nancy and Fatima, you can take the floor.
I think we will consolidate the questions, look at them again, and then we can revisit them in the next webinar in the interest of time. So back to Triphonie.
Okay, thank you very much. It's really exciting, and I hope this is the first series, the first webinar of series that we follow. I'm really happy that it has been very interactive. And now, in the interest of time, I want to give the floor to Jennifer Nyoni, who is our focal person for health workforce, to say something, how she felt, what are the recommendations that she can give us, because she also have another meeting immediately. So I want to give the floor to Jenny. Jennifer, you have the floor.
Thank you, Triphonie. Thank you, colleagues. I really want to thank you for this opportunity to say something indeed. I will start by acknowledging the role that the midwives play in reducing maternal mortality in our countries. And with this new normal, to especially acknowledge them as part of the core team of health workers who are providing care in the context of COVID-19 pandemic. And some have and are infected as we speak, while others have even died in the process. So it's really something that our unit is concerned about, and we are actively following to see how we can support. So I just thought it is important to acknowledge that. As you may have mentioned, the previous speakers in the opening remarks, midwives as other health workers face many challenges. And I know Fran will hear this again, that the sad aspects that at least even 53% of them at last survey feel disrespected by other health professionals. And there are other challenges facing them as well as part of the health workforce, including high levels of workload due to shortages in countries, but they still soldier on providing care. Hats off to all of you. So as a region, we really appreciate this effort of capacity building. And to that effect, some of you are aware, we have produced the prototype curriculum for midwifery as an effort to try to standardize minimum standards that we believe will contribute to ensuring quality. We have one also for nursing and also integrated one. We also have the regulatory framework that many countries are using. Even other regions have made reference to that promote enforcing standards in countries. And also you may be interested, Chair and colleagues, that the current health labor market analysis that we are doing countries also try to confirm the needs of countries for the number of midwives that are required and of what quality. So these efforts are towards that. We are also this year going to produce a regional report on nursing and midwifery to recognize the role of midwives and nurses. We also have done a project recently in 4 countries focusing on rural schools on the competencies of midwifery educators so that the lessons from there can inform processes like this. I would also like to acknowledge the partnership with the World Continuing Education Alliance for strengthening the capacity of health workers through their digital forum, which is very appropriate during this new normal. Also, we thank them because they are coming with a new opportunity to strengthen the training of our health workforce in other areas of women's, children, and adolescent health. But as a recommendation, Triphonie and colleagues, and as alluded to by the earlier speaker, we may need to begin to work towards institutionalizing these initiatives with our national training institutions, including our collaborating centers for nursing and midwifery, so that the training is more accessible to those who need them, especially those who may not really have access to these virtual forums that we organize at global and regional levels. And then this can be also an opportunity to provide this kind of orientations and training in a more systematic and sustainable basis. So the launch of this guide to me is very important. And you can see from the numbers who registered and the numbers who've been able to participate because of connection challenges, which are a reality in our region. So I think it's very important that if all of us can coordinate and see how we can make sure that this guide reaches all the audience, those midwives who are in those places on the front line and they need to access it. So I really want to thank you organizers, and we'll continue, Triphonie, to work with you to see how this guide can reach every midwife in our countries. Thank you very much. Over to you.
Thank you very much, Jennifer, for really the observations that are very, very helpful, but also we take care of the very important recommendation that you just gave us. And we look forward to continuously collaborating with you. And we look forward to the regional report on midwives. It will help us to also do the advocacy for increasing of the number of midwives in the region. Thank you very much. And really, I want to thank you for the time, because I know you have another meeting that has already started. Thank you very much, but we continue to invite you for the next series, and then we hope you'll be able to be available for us. Thank you very much, Jenny.
Thank you, you're welcome. I'll make every effort to do that. It's always a pleasure to meet with people who contribute to saving lives. Thank you very much, everyone.
Thank you very much. Thank you. Have a good meeting. I have the pleasure to invite Fatima to say something. Maybe I'm sure she will address the issue of newborn. Thank you, and you have the floor, Fatima.
Thank you so much, Triphonie. And I'm part of the team, so I will not take a longer time, because there will be in future also we'll be interacting with each other. But one thing what I wanted to say to our colleagues who are joining us today, all the midwives and nurses, and I know there are doctors also in the call, wanted to learn more about it. I know all of us are concerned that how would it be implemented, how would it be endorsed, and would you be able to translate this knowledge into practice in a near future or not? So just wanted to reassure you all that while we are talking, we initiated it. You see, the importance of nurses and midwives, we all understand it. And that's why we initiated our first webinars with our frontline workers, with you, with the backbones of the system. So then, and simultaneously, we'll be working with our OBGYNs also, they're also the backbones. And then we would definitely invite policymakers also. So it's something which we'll be working with all partners together. And then whenever it reaches to your country, like Lesotho, if you are when you sit around the table for the adoption of this or adaptation of this document, you would be in a better position to convince your policymakers, your decision makers, your programmers for the effectiveness of the tool. I mean, we, as from UNICEF, I really wanted to look like one of our colleagues asked about newborn, and I wanted to also see newborn in it, but it's okay because all the things which we are doing in the for mother ultimately will have an impact on newborn. So while we go for adaptation or adoption, we must, like we do with the previous, like the current partograph also, we are trying to, many of us have added PNC component there, newborn component there. We can do the same thing with this one also. So we are really looking forward for your partnership, for your support when it gets to your country, and then you have now all the resources, you have the knowledge, the recent knowledge, and so you have the power to work according to the new standards and guidelines and new evidence. With that, I will stop here, and because we'll get more opportunities to interact. Over to you, Triphonie.
Thank you very much, Fatima, for the encouraging words. Now I think we need also to discuss about the next steps before we close the meeting. I want to give the opportunity to Nancy to present to us what would be the next steps as we move forward. Nancy, you have the floor.
Thank you, Triphonie. Thank you, everyone. And thank you to our very, very experienced panelists for a wonderful webinar today. I'm seeing quite a number of people asking about their pending question, and we just want to reassure you that in the next webinar, we are going to try and answer some of the pending questions before we proceed. So this webinar is in 2 series. And so the part 2 of this webinar will be on 11th March, 2021 at the same time through the same platform. We will continue from section 5, answer pending questions, and then continue with how to operationalize the labor care guide. So be sure to join us on the 11th of March, 2021. For those who are interested in French, we are trying to link with our West African and Central African counterparts to have a similar webinar series for Francophone countries, in which we shall try to have interpretation into Portuguese so that the Lusophone countries can also be able to benefit. There are those who have expressed the interest in this process. We are working specifically with the country offices, the WHO country offices in collaboration with UNFP and UNICEF to organize for the adaptation of the labor care guide as part of the adaptation of the Intrapartum Care recommendation for a positive pregnancy experience. So you just link with your country offices so that they can send the request, and we shall be on hand to provide the required technical support. There are some important links. The publications, you can get them on that link that we have shown on the screen. And then just another announcement that there is a quality of care network and midwifery webinar on March 17th that midwives and nurses, you are also encouraged to join. We have also posted the links to these publications of the labor care guide and the user manual in the chat. And also it has also been posted on the site for this webinar. The presentations are going to be shared on the site and also through the WHO, UNICEF, and UNFPA offices so that you can be able to access them. But the WCEA platform is going to post this presentation on the platform. We also are in process of making this particular training into an online training that you can access under M-Learning or e-learning on the WCEA platform. And once we do that, we shall inform all of you about it so that you can be able to access the online training and go through this in detail. As part of the country adaptation, we shall be also providing the orientation to this labor care guide. So for the country teams, we will do in-country orientation as part of the adaptation process so that you have more stakeholders involved. And we hope to call on you who have attended this webinar to be with us and to support us in this process. With that, I would like to say thank you very much to the panelists, the WCEA, all the participants for a very great webinar today. And back to you, Triphonie. Over.
Thank you very much, Nancy, for the next steps. I want to say that we are still open to your ideas, and I want to congratulate everybody who has participated so actively in this webinar. We want to thank particularly our panelists for really the good presentation that is being acknowledged in the chat box. I want to particularly thank the team who has prepared this the first of this series of webinar. I think, let me say, Mona, Nancy, Fatima, but also with Sam and Craig from the World Continuing Education Alliance that have provided to us the platform. We can also not forget the support of the Swedish government and also really the collaborative work that we are doing in the region. I think I just want to assure you that together with UNFPA, UNICEF, we continue to support you. Please liaise with the different country offices, being from WHO, from UNICEF, from UNFPA. We'll be able to support you to make the reality the use of this new labor care guides. And with that said, thank you very much for having participated. We look forward to seeing you in the next webinar. And thank you. Bon après-midi à tout le monde. Thank you very much. We are really privileged to have you. Thank you. Bye.
Bye. Thank you.
Thank you, everyone, and we hope to see you all on the 11th of March. I think, Sam, you can end the webinar for everyone.
Thank you very much. Have a good day.
Thanks all.